So welcome to the fifth and last of the winter series on aging talk, which is a series which is dedicated to the life and achievements of Dr. Lefeber, who was essentially the founder of geriatric medicine here on the island, and he practiced medicine for many years here. So tonight we're really delighted to have Dr. Jerry Gurwitz as our speaker. Dr. Gurwitz is the founding executive director of the Meyers Primary Care Institute, a joint initiative of the University of Massachusetts Medical School, Fallen Health and Reliant Medical Group, which has the mission to improve the health and healthcare of populations and communities through innovative research and educational endeavors. Dr. Gurwitz assumed the position of chair of the governing board of the Healthcare System Research Network on January 1st, 2015. He has served as co-director of the NHLBI-funded Cardiovascular Research Network, a national initiative that leverages the collective cardiovascular expertise, diverse community-based study populations, and rich electronic data systems across the network to study and understand the epidemiology, prevention, management, and outcomes of cardiovascular diseases. He also currently serves as the principal investigator of the AGING initiative, which AGING is an acronym that stands for Advancing Geriatrics Infrastructure and Network Growth, which is an R24 grant mechanism from the NIH, which provides a research infrastructure that brings together the Healthcare Systems Research Network with the 14 university-based Older Americans Independent Centers, or PEPPER Centers, which one is here in Galveston, to foster collaborative research efforts targeting older adults with multiple chronic conditions. In addition, Dr. Gurwitz serves on the steering committee of the STRIDE study, which STRIDE stands for Strategies to Reduce Injuries and Develop Confidence in Elders, which is a pragmatic clinical trial to reduce the risk of serious fall-related injuries in older adults, which is funded by PCORI and the National Institute on Aging, and of which we are one of the clinical sites. So maybe some of you may have received some mail-outs from us. Please respond if you got it. So Dr. Gurwitz also holds the John Meyers Professorship in Primary Care Medicine at the University of Massachusetts Medical School, and since 2003, he's the chief of the Division of Geriatric Medicine at the same university and the University of Massachusetts Memorial Medical Center. Dr. Gurwitz's research falls at the intersection of geriatric medicine, patient safety, and healthcare delivery science. His career has covered a spectrum from aging pharmacology to medication effectiveness and safety, which he's going to talk about today, and to testing innovative health information technology-based interventions to improve the quality and safety of healthcare during transitions in care across clinical settings. Dr. Gurwitz has been the recipient of numerous awards, including the John Eisenberg Patient Safety and Quality Award for Research from the National Safety Foundation and the Joint Commission. He has also received from the American Society of Clinical Pharmacology and Therapeutics, the William Abrams Award in Geriatric Clinical Pharmacology from the same society, and the George Archambault Award from the American Society of Consultant Pharmacists. So please join me in welcoming Dr. Jerry Gurwitz.
I want to thank everybody. I want to particularly thank Dr. Volpe for the kind invitation to come visit the Seeley Center on Aging. And I just want to say that I've spent my day visiting with and speaking with some of the smartest people that I've ever met in my entire life. And imagine spending your entire day with people like that. I can just say I'm pretty exhausted right now because I had to think hard to talk to them. But it's a pleasure being here today. I am going to talk about something that I think is of interest to everybody in this room, but I want to say that some of my talk is a little technical. And if I bring up topics or say something or use a word that you might not understand, don't hesitate to interrupt me or ask me about it at the end. But I don't care if you interrupt me, and I hope you do. So let's see if I can move this forward. Okay, I'm going to begin my talk with 4 beliefs. Belief number 1. Belief number 1 is important, relevant to those who are prescribers in the room. Knowing geriatric pharmacology means you know geriatric pharmacotherapy, how to prescribe and use drugs in older adults. Belief number 2, most drug-related problems in older patients are due to errors in care and should be preventable. Belief number 3, if we could eliminate the use of a list of drugs called the Beers list, which are bad drugs, in quotes, we could probably eliminate most drug-related problems in older adults. And belief number 4, technology is the answer to all our problems. So let me talk about a couple cases, and these are real people. One I actually took care of. This is the first case, an 85-year-old female nursing home resident with a history of multiple problems, including an irregular rhythm called atrial fibrillation of the heart, stroke, dementia, and hypertension. And she's receiving chronic therapy with a blood thinner warfarin. And her primary care provider has been dosing her warfarin to maintain her in a range that's really acceptable. He or she is trying to reduce the risk of bleeding while preventing stroke in her. One evening, a covering physician is called with a report that the patient has developed a fever. The patient is initiated on an antibiotic to treat what the physician on the phone thinks may be, and people in the nursing home think might be, a urinary tract infection. The next morning, the primary care physician is called with the previous day's INR, which is a measure of how thin the blood is. That measure is saying it's not thin enough. She increases the daily warfarin dose from 4 to 5 milligrams, and she is not notified of that antibiotic that was ordered the previous evening. 1 week later, the INR comes back very, very high. It's sky high, 13.8, which places the patient at a huge risk of bleeding. And a different covering physician is notified. That evening's dose is held. The primary care physician is notified and gives an antidote of vitamin K, and that reduces that level to normal. And that physician writes in the record that warfarin will not be reinitiated because anticoagulation has been difficult to control for unclear reasons. Now, even those of you who are not doctors can see there are a lot of problems here in this person's care. And probably some of you are thinking, well, how could these healthcare providers, this nursing home, these nurses, these doctors have been so stupid? And I just want to tell you that I look at things very differently. I say these exact things could happen to me. And I want to be honest with you, they have happened to me as a provider. So here's a second case, HM. This was my patient, 82-year-old male who presents for the first visit to his brand new primary care provider, PCP. The patient has switched primary care providers many times over the past 10 years. Available records for the patient are disorganized, but mention problems including high blood pressure, hypothyroidism, anxiety, deep venous thrombosis, and atrial fibrillation. The medications are listed there. They include a drug which we just talked about, warfarin, that blood thinner. And the patient's INR is at 2.5, which is perfect, exactly perfect. The new primary care provider searches through the records which document a diagnosis of superficial thrombophlebitis 10 years ago, which wouldn't require this blood thinner, but he can find no outpatient or inpatient records confirming the diagnosis of these things, DVT or atrial fibrillation, which would be indications. The patient has been taking the warfarin reliably. He has been adherent to all dosing and monitoring recommendations. He's suffered no side effects from the warfarin. He is comfortable with being on the warfarin, as that is what his doctors have told him to do. But the primary care provider agonizes over whether or not to stop the warfarin or not. So this is a tale of two patients. In the first case, the patient has been discontinued off a potentially very important and beneficial therapy and really didn't have to be if it was managed correctly. And the second patient, it's weird, the second patient's continuing to take this medication that he maybe never should have been on in the first place. So these are two cases that sort of run through my mind, and I'm going to have you be thinking about them throughout my talk. So a couple of years ago, I was asked to give grand rounds at a local hospital, and the nurse I was working with handed me this pink slip with this written on it. Dr. Pitts called this morning to see if your talk at medical grand rounds tomorrow will be the same presentation from the 70s or if it has been updated. And at first I was a little irritated because I was in high school in the 70s. I may not look like that, but I was. And but then I began to think that maybe Dr. Pitts was right. And the reason I think he's right, potentially right, is that if you look at the science behind the way doctors use drugs in older people in 2017, it hasn't changed much since the 70s. We really don't know that much more than we did in the 70s. And in fact, I have to confess, some of the slides I'm going to be showing you are from articles and textbooks published in the 70s, because not a huge amount has changed. So that's the confession. We're still dealing with an inadequate science. Now, is there evidence of unsafe drug prescribing to older adults? Well, there have been these bad drug lists published, and depending on, thousands of articles have been written on this topic, and depending on the article you read, between 5 and 40% of older adults in nursing homes, in the community, and hospitals are on these bad drugs. And this list was recently updated. But if you look at the science behind this list, it raises some questions. 17 of the recommendations, of the many recommendations, are based on high quality evidence, but 67 on only moderate quality, and 11 on low quality, basically just the opinions of people. So the science behind what I do, what we do, what your doctors do, nurse practitioners that care for you do, when caring for you and prescribing to you is very limited. Now, why is that the case? And there are many reasons for that. But one of the reasons is for decades, older people have been excluded from participation in clinical trials. Now, here is some information from trials of heart attack patients. And if you go look back from 1960 to 1991, over 60% of those trials explicitly excluded older people from participating. Now, that percentage has declined over time from 40% to 30% more recently. But if you look at the average age of people participating in those trials, it hasn't changed much at all. It's changed about a year or two. Now, the trials don't exclude older people, but older people aren't participating in the trials. So we're left with a quandary, a dilemma, that we're prescribing drugs to older people, but the drugs have never been studied in them. So we don't really often know what's going to happen. The other reason older people are excluded from participation in these drug studies is because of something called multimorbidity. The most common chronic condition in older people is having more than 2 medical conditions. But many of these trials will exclude people with more than 1 medical condition. And who has more than 1 medical condition? It's older people. So by definition, they are being excluded. Okay, so we're going to switch gears a little bit and talk about the factors that influence drug effects and the risk of adverse effects in older people. Now, many of these are intuitive. Older people have multiple coexisting medical conditions. The more conditions you have, the more drugs you're going to be on, by definition. Many of these drugs, though, can have redundant effects or lead to drug-drug interactions. Adverse effects are sometimes nonspecific, so we don't recognize them as adverse effects. And there are many pharmacologic changes that occur with aging. So, with apologies, I'm going to start talking about pharmacology, which many of the medical doctors and nurses in the room remember probably not too fondly from medical school and nursing school. But so I am going to get into a little jargon, so with apologies. So everything I know about geriatric pharmacology I learned in the 80s because not much has changed. Now there are 2 things in pharmacology that providers, prescribers need to think about. These are 2 technical words. Pharmacokinetics is the first one. Pharmacokinetics is what the body does to the drug. It includes absorption, often from the gastrointestinal system. It includes distribution of the drug. The drug distributes across these different compartments of the body. It includes metabolism, which is the breakdown of the drug in the liver, and it includes excretion. These drug products are excreted in our urine and stool when we take a drug. Okay, so the first problem dealing with aging is this. As we get older, we get fatter. It's sort of an inevitable. Does everybody realize that? Who realizes that in this room? It's an inevitable consequence of aging. And it's not necessarily that our total body weight increases, it's the distribution of that weight. We gain fat at the expense of muscle mass. So even if your weight's the same as it was, which it is in high school, you have more fat than you had in high school, and you have less muscle than you had in high school. And why is that important? Okay, doesn't this look like it's from like the 70s? Okay, because it is. And it's important because the compartment of the body in which these drugs accumulate can change with aging. Because if a drug likes to accumulate in the fat part of the body, the amount of space it's going to have is going to increase. So in the top part of this graph, which you can't see from the back, but you do see the line going up. This is a drug, Valium. Who's familiar with that word, Valium? Okay, that drug is very fat soluble. It loves to accumulate in the fat compartments of the body. So the space that drug accumulates can increase with older age. Now a drug that doesn't like to accumulate in the fat, that's very water soluble, that's the muscle. So muscle mass goes down, the place, the volume of distribution for that drug is going to go down, and that's the bottom panel. Okay, some more jargon. Breakdown of drugs in the liver. Now, there are some pathways in the liver that break down these drugs that decline in efficiency as we age. And there are other pathways that don't decline in efficiency. If we know potentially how a drug is metabolized in the liver, we can make maybe theoretically some better choices as prescribers. And here's another thing. Our kidneys don't work as well as we get older. It's not true for everybody, but if you look at a population that ages, you're going to find a decline in the way the kidneys are working. And remember, these drug products are excreted in the urine. So, this is for the mathematicians and pharmacologists in the room. This is an equation, the only equation I'm going to be showing you, which says half-life, and that's a measure of how long the drug stays in the body, is proportional to this volume of distribution divided by the clearance of the drug. So I'll make this hopefully a little clearer. If you have a drug that's very fat soluble, that loves to accumulate in the fat of the body, in an older person, that's the volume of distribution, that number will increase. If you have a drug that's metabolized or broken down by the liver or excreted by the kidneys, in an older person, that's the clearance of the drug, and that will decline. So you can try this at home. If you divide a bigger number by a smaller number, you end up with a bigger number. So I'll bring this home to you. The half-life of Valium in a younger person is about 40 hours. But the half-life of Valium in an older person, like some of you and me, is 70 to 80 hours. Just based on the things I talked about. Those are big differences. So the other thing, I talked about pharmacokinetics. Remember, there's going to be a test at the end. It's going to be multiple choice. Pharmacokinetics is what the body does to the drug. Now, pharmacodynamics is what the drug does to the body. Okay? So, as we get older, we get, not only is the drug being handled differently by our bodies, but our bodies become more sensitive to the effects of drugs. So here's another graph from the 70s. Okay, so this is a study of people undergoing something called electric cardioversion. Has anybody in the room ever had that done to them? Can you raise your hand? Okay. So that's where your heart's in abnormal rhythm, and the hospital wants to get it back in the normal rhythm and shocks you. Now, sometimes it's an emergency, but sometimes it's not. If it's not an emergency, even if it is an emergency, they're going to try to sedate you. So what they did is study these patients undergoing this procedure, which hurts. It hurts when they shock you. Well, you didn't remember because you know you were sedated.
Sedated.
Yeah. So that's the good thing. You were sedated, thank God.
Yes.
So on the vertical axis is the concentration of diazepam or Valium necessary to make the person not respond to a verbal stimulus, but if they squeeze their fingernail really tight, they would respond to that. So not respond to a verbal stimulus, but respond to a pain stimulus. And on the horizontal axis is age. You have to take my word for it. This graph shows that the amount of Valium necessary to have that response in an older person compared to a younger person is less. That means that older people are more sensitive to the effects of this drug. And that's a pharmacodynamic change with aging that you could think might increase the risk of bad things happening to older people on a drug like Valium. Okay, so belief number one, I spent a lot of time trying to convince you of this, that knowing geriatric pharmacology means you know geriatric pharmacotherapy. And now I'm going to tell you that that may not be true. So I just wasted all your time. So here's a study, and you can read the bullets if you'd like, but it's a study looking at older people who suffer a hip fracture. And the risk of suffering a hip fracture if you were exposed to a drug, a benzodiazepine, which is the family that Valium is in. And there are benzodiazepines that we can prescribe that have long half-lives like diazepam or Valium, or very short half-lives. And you would expect, based on what I told you, that if you prescribed a drug that didn't hang around the body as long as Valium does, that the risk of side effects like falling and fracturing your hip would be less. But now I'm going to tell you that's not true. That it doesn't matter what sedative agent your doctor prescribes to you, that you're still at great risk. And that risk is greatest really when the prescriber starts the drug. So like the first 2 weeks that you're on the drug. And it's less as over time. But that's the greatest risk is early on, and it doesn't matter whether your doctor knows pharmacology or not, seemingly. Okay. And how many of you, well, I'm not even going to ask this. Ever heard of this drug? Zolpidem, Ambien. It's a very short-acting agent, and it's probably the most commonly prescribed sedative hypnotic in this country right now. But there are risks, even this very short-acting agent, there are great risks of side effects like falls, injuries, and fractures. Okay, I'm going to talk about physics. Who took physics? Okay, physics, there are all these principles in physics. I'm going to talk about therapeutic momentum, which has nothing to do with physics, and therapeutic inertia. Therapeutic momentum is when a prescriber or a provider adds drugs to your regimen for questionable indications. And therapeutic inertia is when your prescriber continues drugs in you when the drugs aren't helping you at all. Can you imagine some of these things? Think these things ever happen? They do. I'm guilty of these things, so. Okay, so here's something called the prescribing cascade. Maybe this has happened to you. A drug is prescribed by your doctor. You suffer a side effect to that drug, and a second drug is prescribed to treat that side effect. You see this advertised on TV all the time right now. Opioid-induced constipation, there's a new drug for that. Who's seen that advertisement? Might have been a Super Bowl advertisement. But that's where an opioid is drug one, patient suffers constipation, doctor prescribes drug two. So these things happen, and sometimes drugs are so important, like chemotherapeutic agents, that your doctor will do everything possible, your healthcare team will do everything possible to keep you on that drug, even if they have to prescribe other drugs to treat the side effects of those drugs. But sometimes, maybe you could have been on a lower dose of drug one. Sometimes maybe there's a safer drug than drug one, an alternative. Sometimes maybe you don't need drug one at all. And sometimes, believe it or not, the doctor doesn't know that that adverse drug event was a side effect of the drug. the doctor thinks it's a new condition and prescribes drug 2, not recognizing that prescribing drug 1 caused the problem. So here's an example of something like that happening. 77-year-old woman with urinary urgency, feeling like she has to go all the time, gets a drug called nifedipine for hypertension. That leads to swelling, constipation, and it makes it harder for her bladder to empty. She starts going to the bathroom more at night, getting up to go to the bathroom more at night, feeling of urgency like she has to go, some little incontinence of urine, and the doctor diagnoses something called overactive bladder, which leads to a prescription of a medicine to treat that, which leads to constipation, which leads to laxatives, and everything related to that first drug, and no one sort of picked that up. So this is an example of a prescribing cascade. And there are many examples of this. Non-steroidal anti-inflammatory drugs like ibuprofen, naproxen, or naproxen can lead to increased blood pressure, leading to the need to start an antihypertensive medication. Thiazide diuretics can lead to gout. Steroids can lead to high blood sugars, which lead to treatment of diabetes. Drugs for dementia can lead to incontinence, which leads to the need for these anticholinergic drugs. And this drug for, which was previously used to help the stomach empty, can lead to symptoms that look like Parkinson's disease. So all these are prescribing cascades that ideally should be picked up and something should be done about them, short of prescribing new drugs. Okay, so now we're going to belief number 2. Most drug-related problems are due to errors in care and should be preventable. So I'm going to tell you about a study we did in nursing homes, and to understand this study, you have to understand this, that there's this huge universe of medication errors happening out there. They're happening all the time, every day. And older patients are like dodging these bullets that they don't even realize are there. But thank God, most medication errors don't turn into injuries to patients, but sometimes they do. And these injuries we call ADEs, or adverse drug events. Now, sometimes these injuries or bad things occur and we can't prevent them. So if your doctor prescribed to you penicillin for strep throat, and you had never gotten penicillin before, and you had an anaphylactic reaction that landed you in the ER or the hospital or worse, that probably in 2017 couldn't be prevented. But if your doctor knew, because it was in the record somewhere, or you knew that you had been allergic to ampicillin at one point, which is related, which is a penicillin, and for some reason you got the penicillin, landed in the ER with the anaphylactic reaction, that's a preventable adverse drug event. That's due to a medication error. So that's what, in the work I do, we're most concerned about those things, because those, I mean, these other things are interesting, but we want to find things that are preventable. So we conducted this study in 2 large nursing homes, very large nursing homes, and we identified 815 drug-related injuries to residents of these facilities. It was about a rate of 10 per 100 resident months. So the average nursing home in this country is about 100 beds. It's about 120 drug-related injuries in that nursing home per year. Now, not all of them were due to errors. Most of them weren't. About 40% of them were due to errors. Now, These were some bad things: 4 fatal events, 33 life-threatening events, 188 serious events. And where did the errors occur? They occurred at the ordering of the drug, so decision related to ordering and prescribing, and monitoring of the drug therapy. There are a lot of errors that occur in dispensing of drugs. I mean, sometimes the wrong drug is dispensed by the pharmacy, or in administration, like giving a drug late. But most of the time, those things don't lead, fortunately, to injuries. The things that lead to injuries are errors, that most commonly lead to injuries are the errors in what we as doctors, nurse practitioners, and PAs do. So it's to a large extent, our responsibility, ordering drugs and monitoring them. Now, what kind of events occurred? Neuropsychiatric means things like delirium or confusion, bleeding events, gastrointestinal events, kidney problems, falls with injuries, and fainting events, a bunch of things. And these are the drugs that cause these events. And let me ask some of the prescribers in the room, what's special about this list? If you're a prescriber, you get to answer this.
A lot of our patients are on manual.
Okay, so Dr. Volpe is saying a lot of my patients are on these drugs, and she got the right answer. The answer to this question is there's nothing special about this list. This is a list of drugs that doctors, nurse practitioners, PAs are prescribing all the time. There's nothing special. Now, if you extrapolate our findings to the entire U.S. nursing home population, that means there are 1.9 million drug-related injuries per year, 40% preventable, and 86,000 life-threatening or fatal events per year. So these are common.
I'm sorry, you might have said it, but I didn't catch it. How do you define preventable versus not?
Okay, we went through a long process, and the histories of these people who suffered these events was abstracted from the medical records, and then 2 physicians independently, based on the story, assessed whether there was an error or there wasn't. Now, they did that independently, and they had to agree with each other that an error had occurred, and they put the error into one of those 4 categories that I mentioned: ordering, dispensing, administration, and monitoring. So it's a fairly rigorous process.
But in a previous graphic, you showed a large circle for medical errors and a small area for preventable.
So that's a good point. We didn't study medication errors. We started off by trying to find the injury, and then we worked backwards from that. So we didn't start off trying to find every medication or medical error. We started, okay, here's somebody that suffered something, and now we've identified it as an adverse drug event. Was it preventable? And what were the errors? So that would have been a different study. That would have been a much more ambitious study, because only about 5% of these errors turn into these events. Okay, so one thing I sort of brought up earlier is if we could eliminate drugs on the bad drug list, could we eliminate most injuries to patients? That would be great if we could do that. If we could just eliminate use of certain drugs. And the answer is, I'll give you the punchline. The answer is no. So what are the heavy hitters in terms of drugs that cause injuries to people, like all of us? You've heard of this drug before now: warfarin, the blood thinner, antiplatelet agents, like Plavix is one that you might have heard of, insulin and drugs for diabetes, opioids, and antibiotics. Those are the drugs that most commonly lead to injuries in older people. Medications on the Beers list in this huge national study that led to people being sent to the emergency room or presenting to the emergency room, older adults, medications in that bad drug list accounted for less than 2% of all injuries. So, many of the drugs I just mentioned are not on the bad drug list. So that's one take-home point. So finally, technology will solve all our problems. Who thinks that's true? Okay. One person does. Okay, so we set up a system in nursing homes so that when prescribers prescribed a drug that might have a risk to a patient, or a risk was identified, that an alert would show. And half the units of these nursing homes got these alerts and half didn't. And then we tracked injuries that occurred to residents of these facilities. And just very quickly, here are our results. In the units where there was this intervention going on, where the doctors saw these alerts, there were 10.8 injuries to patients, basically per month, and per 100 beds, and the same number, same rate where they didn't get the alerts. So, and if you looked at preventable events, events related to errors, same thing, no difference. So, massive failure, and for every complex problem, there is an answer that is clear, simple, and raw, unfortunately. And there was a lot of reasons that this didn't work. One of the reasons that maybe the doctors in this room and providers clearly, I know if I put them in by themselves, they complain a lot about this. They get overwhelmed with alerts. So what happens when you get overwhelmed with alerts? It's called alert burden. You start clicking through the alerts and you don't even read them. That's just one problem. Okay, we're going to end with this, an inconvenient truth. In 2000, 24% of Americans aged 65 and older used 5 or more prescription drugs. In 2012, that percentage is nearly 40%. So we talk about this thing called deprescribing. And deprescribing is the systematic process of identifying and discontinuing drugs in instances in which existing or potential harms outweigh benefits in the context of a patient's goals, function, life expectancy, values, and preferences. This is what's being advocated right now. And just to summarize this, we're not doing a good job of this at all. These are just some examples of people who are being overtreated for their blood pressure, placing them at risk of bad things happening like falls, or overtreated for their diabetes. This is happening a lot. Some of you in this room are studying this. So what are the steps of deprescribing? One is to ascertain all the drugs the patient is taking and the indication for each one. Assess each drug in regard to its current and future benefit relative to its current and future harm. Prioritize drugs for discontinuation that have the lowest benefit-harm ratio and the lowest likelihood of withdrawal reactions. And monitor patients closely for improvements in outcomes or onset of adverse effects. So, which drugs can be deprescribed? If a prescriber can't identify the diagnosis for which the drug was prescribed or substantiate it, that's a good candidate for taking a person off that drug. Was the drug prescribed to counter an adverse effect of another drug? Remember the prescribing cascade thing. We need to be looking for those. Is the drug continuing to confer benefit? So a lot of people in the end stage of their lives still being on a drug to control their cholesterol levels or to prevent osteoporosis and hip fractures. Are those drugs needed, still needed? Do the benefits of treatment outweigh the risks? Overly aggressive treatment of high blood pressure or diabetes. So, like anything, there are risks involved, and I'll close with a few risks. There have been cases where patients have been taken off a drug for their heart failure. Well, some of those people go into heart failure. Patients who are taken off of antipsychotic drugs, who have Alzheimer's disease, well, some of those people relapse into psychosis. Most of them don't, but some do. And patients discontinued off of benzodiazepines like Valium, well, some of those people have withdrawal symptoms and go back on the Valium or other drugs like it. So there are risks involved in deprescribing. So I'm going to close with, remember the 4 beliefs? So I'm closing with 4 myths. The beliefs have become myths. So myth number 1, knowing geriatric pharmacology means you know geriatric pharmacotherapy, how to prescribe drugs to older people. That's a myth. Myth number 2, most drug-related problems in older patients are due to errors in care and should be preventable. The majority are not preventable. Many are, but the majority are not. Myth number 3, if we could eliminate use of drugs on the Beers list or a bad drug list, we could probably eliminate most drug-related problems in older adults. Not true. Myth number 4, and which you're all sad about, technology is the answer to all our problems. And finally, deprescribing, to the prescribers in the room, just do it. So thank you. Thank you for your attention.
Gurwitz, and now it's the floor is open for questions. I'm sure that a lot of people are going to have a lot of questions. Kyla.
Well, thank you for a very nice talk. And my question is about how can we incorporate pharmacists, we are our patients through their medicine, into reducing some of these medication and hopefully preventing some of the adverse drug effects.
Yeah, so the question was, how can we incorporate pharmacists more in addressing some of these issues and preventing bad things from happening to our patients and all of you? So that's an interesting question. 2 things I'll respond to you with. One relates to the literature, and one relates to a project I'm involved in right now. And the first one is there's very limited information on the effectiveness of pharmacists in preventing harms to patients, unfortunately. Pharmacists are among the most respected discipline of healthcare professionals, by the way. My wife's a pharmacist, but I want to be honest with you, there isn't much in the literature to show how that pharmacists prevent bad things from happening to people like us. The second thing, and this is one of the studies I'm working on right now, which is turning into a massive failure. Okay, so I'm doing a study with a group of people, and what we've identified is older people discharged on those medication categories that I showed you. Warfarin, antiplatelet drugs, opioids, diabetes medicines. Older people discharged from the hospital. And we're calling people up and saying, we'd like a clinical pharmacist to come into your home and visit with you within 3 days of you getting out of the hospital. And to go over your medications with you, to talk about your medications, to look if they can help you organize meds, and people won't let them into their home. They're refusing. They're too busy, they're too sick, they already know enough about their medications. VNA's coming, there's 100 excuses, but we can't even, they're getting this for nothing. But in fact, they're getting a gift certificate if they let them in the home, $25. But they won't let them in. It's crazy. I don't know what to do.
Other
No,
questions? So I have a question. Many times when I'm one of those deprescribers when I see patients. But sometimes the patient is resistant to the deprescription just because they've been on the medication for such a long time. Or maybe they don't like the change in goals, say, hey, my blood pressure, the doctor, my cardiologist said it used to be 120 over 80, and I want to have it that way, and then they're falling. And so it takes a lot of convincing to these patients. What would you say to the patients when something like this happens?
Yeah, I think Dr. Volpe is emphasizing one of the key challenges for all of us. And I think one of the biggest challenges I deal with is the lack of time. I only have so much time. My schedule, and it's more generous than other physicians I practice with, allows me 20 minutes with a person. And what she just described is a process that takes a lot of time to go through an explanation, especially with a questioning patient or family member. And do I have enough time to allot to that? And it's like a stopwatch in there. And I'm running out of time. There are other things I have to do with that person, and how much conversation am I able to have? I think that type of conversation usually, for me, it takes more than one visit. It's unlikely that it's unlikely that I'm going to be successful the first time around. I think the things I struggle with the most, because it becomes a much longer conversation, is the therapy that a person's on at the end of their life. So I know that person, doctors are bad at prognosticating, but I know that there's a good chance that person's not going to live more than 6 months. And the person's on a drug for osteoporosis or for their cholesterol. They might have metastatic cancer. And that's a harder conversation than I would expect under that circumstance, because it brings up a whole bunch of other issues. The right thing to do is to get that medication regimen as streamlined as possible. You don't want a person on more drugs than they need to be on, but there seems to be an attachment to these drugs they've been on for, decades, and it's symbolic of something else to come off them. That's just my feeling.
Okay.
What's your opinion about complementary and alternative herbal medications? And many times the patient don't consider them as drugs because they are natural products. And I'm just wondering, within the context of this talk, errors and myths, I just want your comment on those.
Yeah, that's also a huge challenge for me, because psychologically I don't even want to talk about that with a patient because it's so hard. One thing, I sort of focus on science, and I really do. I try my best to, and I try not to just Google things and get my information that way. And when I tell a person, they're looking to me for answers. Is this the right thing to do? Is it the wrong thing to do? Is this the right dose? Does it interact with other medicines I'm on? Should I be on it? I want to be on it. My sister-in-law says to be on it. You know, and I tell them, you know, there isn't a lot of science behind this, so it's hard for me to give you a good answer. But I prefer that you're on as few drugs as possible, and there are some potential risks that we might not know about. And yeah, that's a hard one too, especially when they've spent a lot of money, you know, that they've heard about some infomercial, and those drugs on TV, those supplements on TV are very expensive, so they're kind of mad when I say that might not be worth taking, and they've spent $50 on that bottle. But, do you have the same?
Particularly when there's a claim of miraculous cure,
Yeah.
the ancient remedy, you know, 30% 30 pounds weight loss in 1 week, things like that.
Yeah.
Stop.
And they also, don't they also increase the confusion, you know, when you have another bottle of medication or a supplement,
Yeah.
and so you keep popping pills, and eventually you may actually miss the good one for
Yeah.
one of this supplements. Yes,
Isn't it? Why don't I be like, oh, do you want to?
yeah.
Let me
no,
let-
Yeah, well, I was gonna ask, talking about deprescribing, how, and I'm sure you have an answer, but a question comes to my mind, the role of the physician, the prescriber, in resisting deprescribing. Because I ran into it sometime after my heart operation. I was on 10 or 12 different medications. I was really worried about all these medication interactions, all the stuff you're talking about. And I said, you know, can we take this, let's talk about taking some of these drugs. No, you're in a good place, let's not change anything. Didn't you want to discuss it? And so,
Well, I think, thank you for bringing that up, because I think one of the things that all of us need to be a little more maybe assertive with our healthcare providers and ask as many questions as possible and keep bringing up things like that. You know, do I really need to be on all these medications? And are there any that we can think about stopping? And if you ask that question over and over again, something's probably going to happen, because the doctor will be sick of hearing.
wear them down.
I just don't want to skip over.
I wanted to ask a question from a caregiver point of view. In a situation where we're dealing with multiple chronic illnesses, multiple doctors, different specialists, we term this our medical go-round. And we have sophisticated calendars and long lists of medications and where they come from and the dosages, and it's a big job. We cannot get, or how do we get, all of those professionals to address us as one patient. We are dealing with this cacophony of advice coming to us. It sometimes contradicts with other advice coming to us. We don't understand as patients of your system how to get us into your collaboration, if you have a collaboration.
Yeah, so that's a remarkably important point about you're describing the chaos of the American healthcare system.
Well, right now, and I don't know that it's chaos. I mean, I've worked in healthcare myself to understand the medical people understand their systems. We don't know how to interface with that, but presently, my husband's taking 23 pills a day. It's a complex schedule.
Well, I think there are a couple of things. The short-term answers are a couple of things. One, it's good to have a good primary care provider who you trust and listens to you and is responsive, because the ideal primary care provider is supposed to be sort of coordinating a lot of that. And that's a hard job for a primary care doctor. And one of the reasons a lot of people don't want to go into primary care, but that's one of the primary jobs of the primary care doctor. The second thing is being in a healthcare system where there's a single electronic health record that every provider you go to has access to. And this is also difficult because a lot of patients are going to providers who are outside of a single healthcare system. And you use multiple electronic health records, but that's fantastic in terms of everybody at least having the possibility of knowing what everybody else is doing and what everybody else is prescribing. The other thing is something that we aspire to, a healthcare system that actually coordinates care for patients where everybody's really in a healthcare system and not doing what you're doing, which is basically you're creating a healthcare system. You're the quarterback. You're the primary care physician provider. We're doing everything.
Except being as informed as you are.
Thank you very much.
UTMB Health.
And
Working together. Productivity.